The way that I generally do the support group, because the support group is really for everyone that's here to get some of their concerns and questions addressed, is to go around, have people introduce themselves. We have a very big turnout, and maybe tell us, if you would like, a little bit about yourself and what you want to get out of the meeting tonight. And it doesn't have to be very detailed, but that will give me some idea on how to direct the support group. Again, the support group is for everyone, because I think we can all learn from each other and our experiences. If you don't want to ask a question, you don't have to. We'll just go on to the next person.
I'm Emily, and I had surgery in 1999 with Dr. Kelly and Dr. Becker for prolactinoma. It was good surgery. But I've been doing follow-up with Dr. Van Hurley and now Dr. Cohan. And the title of the meeting really struck my fancy because hormones are an issue with me. So are we supposed to bring up our concerns?
Yeah, what you thought that you want, some things that you wanted to leave this meeting with having answered. Or maybe you just wanted to get general information. That would be fine too.
Yeah, general information is good. My personal issue is things seem to have been going well, menstrually speaking, but they've stopped as of early this year, and so I need to get seeing you again. And I've had some insurance issues which have been resolved, and I'll be able to see you soon. But I just wanted to know if this is typical or just anything you had to offer.
Okay, thank you. We'll talk about that. So I think one thing that we'll realize after everybody had a chance to talk is that there's lots of manifestations of pituitary disorders and lots of things that could potentially happen even after successful surgery. And so we'll address prolactinomas and what to expect afterwards. Thank you.
My name is Ray, and I'm 63 years old, and I was diagnosed with Cushing's disease earlier in the year, and Dr. Kelly performed pituitary removal of the tumors on the 3rd of May. And I want general information. I'm just thrilled to hear two ladies say that they too had Cushing's. I didn't allow myself to look on the internet before my surgery because I was really afraid to know exactly what Cushing's was all about, and I just thought I'll wait and see if I live through the surgery, and then I'll worry about it. So I'm basically wanting general information. And like you, I was intrigued by the heading on the announcement because I think it said hormones, you can't live without them, and you can't live with them, and you can't live without them. Is that
Okay, that wasn't exactly his topic. So
That's
I had lived for him, but just so you know, and everyone seemed to like the topic. It was hormones, hormones, hormones. We can't live with them, and we can't live without them. Okay, so now you now, just so you know, that wasn't his professional topic.
You can live without
Right.
them, and I thought, well, that's what I wanted to do. I want to live without them, and I was wanting to know if that was actually a possibility.
Yeah, we will talk about that. Most of the pituitary hormones can be replaced, fortunately. And one of the things we'll discuss today is that no matter how hard we try to mimic normal physiology and normal replacement with hormones, it's difficult to get it 100% right. And I think that's why trying to replace hormones can sometimes be difficult. A lot of patients may find the balance easily, and some it may take a lot more work. But we can't really replace hormones perfectly as the body would have made it otherwise. So we'll talk about hormone replacement as it relates to Cushing's disease.
Okay, thank you.
Hi, my name is Silke. I've been operated at Kaiser 5 years ago. At that time, I was told I had a non-secreting tumor, but it looks like that was a wrong diagnosis. I'm diagnosed with Cushing's right now, so it looks like they have overlooked that in the beginning. and it seems to be intermittent. So sometimes I have sky-high numbers, and sometimes it's fairly normal. So I'm going through up and downs, and that's why I was interested in the hormone issue too.
Thank you. We'll talk about cyclic Cushing's.
Because you don't find much about it.
That's right.
Mm.
And it could be very difficult to achieve the right diagnosis. So
Yeah.
thank you. We'll talk about that.
Okay, my name is Marcia. I have Cushing's. I was diagnosed last fall after about 7 years and had surgery April 4th at USC with Dr. Liu. They won't guarantee me anything, but they expect that they got the whole tumor, and I felt so much better. But a couple of issues that are bothering me a little bit, and they may or may not have anything to do with hormones, but I'll bring them up because this is what's bothering me in my recovery, is nausea. Since the surgery, my appetite is better, but I still have nausea most days. And what I call the itchy twitchies at night, where I'm just so itchy and I can't sleep and I toss and I turn, and I don't know if that's part of it too, but yeah.
Yeah.
Thank you.
Okay, good. Well, it helps know when I'm not the only one. And just general information on recovery, which takes longer than I think it should some days.
Thank you. We'll talk about it. The recovery from Cushing's, as you'll learn from a lot of your peers, and from Charmin, if for those of you who've communicated with her, is probably the most difficult of all the pituitary tumors, and we refer to it as the biggest roller coaster ride in your life, and I think when I've talked and spoken to patients who are recovering from Cushing's disease, and they list all the symptoms that they feel, it's essentially anything that you can imagine. And so now, when a patient asks me, could this symptom occur related to recovery from Cushing's, the answer is yes, it's possible, because it can affect so many different symptoms, and have so many different signs. So we have already several people with Cushing's disease here.
I had Cushing's for 15 years, so I was very sick by the time I was diagnosed. It took 15 doctors before I was diagnosed, too. And I had surgery 3 years ago, and the first year was almost harder afterwards than it had been being sick. But it seemed like after I hit a year, I felt like I'd been given my life back again. You go through so many changes after surgery. Within the first 6 months, I lost a third of my body weight. Changes were that dramatic, but for the last 2 years, I've just been feeling incredibly healthy. And a friend who goes to a lot of support groups reminded me that support groups aren't just for when you're having problems, but so other people can hear your success too.
Right, that's so true. A lot of times what you see on the internet and are people who've had negative experiences, so it's nice to see someone who's gone through it and is now doing very well. The first few months is a very difficult period because your body is looking better and going back to how it was before, yet you feel horrible. So, and the two of them make it very, very difficult. Thank you for coming.
My name is Maria. I had 2 surgeries here with Dr. Kelly and Dr. Cohan. One is my
Not the surgeon, though.
Not the surgeon, but he had a major role in it. I had radiation treatment.
Tell
I
us
also
what-
have Cushing's.
Okay, good, thank you.
Which has been very hard. I'm just here just to learn and see what's going on. Cushing's goes down and up. I guess I've never heard of that before, but it's the same. One time I go in a couple months and it's low, and then I go in next time it's high, and it's just not stabilizing. So they're just looking at other alternatives to do some scans and nasal sampling or something. Yeah, so that's where I'm at now.
Thank you for coming. Yeah. So another person who has variable cortisol levels depending on when we measure it, and one thing that we know about hormones in general is that there is, even in normal persons, there's a rhythm and a normal fluctuation to the release of hormones. In people who have pituitary tumors, it's not an exception either. Their tumors can have periods of time when they're active and periods of time when they're quiet. So depending on when you measure the level, you can find it high or you can find it to be normal. Or in fact, you can find it to even be low. Thank you for coming in.
My name is Frank Clark. I had the attempted pituitary tumor removal in 1999, and they were not successful because I bled out and I had a stroke during the surgery, so they weren't able to remove it. But in the meantime, the tumor itself is non-producing, so I'm still, I'm taking prednisone every day and Synthroid for my thyroid glands. I was taking testosterone injections for a few years. Then all of a sudden I was diagnosed with prostate cancer, so I had to stop taking that. And now it's down to like 10, and my energy is about the same. I mean, I have no energy. So that's why I'm interested in how to live with hormones.
Thank you, Frank. So a tumor that was not producing a hormone still can cause serious hormonal problems.
It left me blinded in one eye for 3 years. And my stroke, but I had to get over that too. So now that I'm sort of on my way, I want to try and cure the hot flashes and the hot, sometimes I'll be sitting down and I just start perspiring and I just can't stop, unless I let it dry up itself. Or I'm cold or I'm hot. I mean, I thought that only happened to women.
And it doesn't. Men get hot flashes. Men who have testosterone deficiency can have sweats and hot flashes just like women. It's essentially a lack of either estrogen or testosterone that would do that. The complicated point here is that you're not able to get testosterone because of another condition that developed, and at this time almost every doctor would not give a person with prostate cancer testosterone because testosterone can make prostate cancer grow. In fact, a lot of you may know that in the past, even presently to some degree, one of the treatments for prostate cancer is to give a medicine that lowers testosterone.
Absolutely.
So we'll talk about hormonal replacement and some complicated factors that can come about with other conditions.
I was going to say something else, but I forgot.
When you remember,
I'll
you'll
remember.
let us know.
Do you want to go, Sharon, do you want to go ahead and, we're just giving kind of a brief explanation of why you come, what you'd like to hear from Dr. Cohan.
Why I come? Because I love the drive from Santa Clarita.
We love you here, so.
Welcome.
See the sights of the city. I had an emergency with a brain tumor when I was in South Dakota on vacation. So that was the first introduction to acromegaly. Never heard of the disease, disorder. Had no clue. I was just vacationing, having a good time. The next thing you know, I was medevac to the Mayo Clinic. So this thing was hemorrhaging, and I was fighting for my life. I had about a 1% life expectancy, and the guys looked at me like there wasn't too much hope. Told my poor husband expected I'd be dead, blind, paralyzed, or in a vegetative state. And instead, ta-da, 7 years later. I've got no pituitary, I've got cortisol function, my hormones are flat, dead, gone. My body looks like a giant pillow. I keep telling people I'm like Humpty Dumpty. As long as I'm up, flat, or sitting, that's about the only positions I've got. Something hits the floor, it stays there. Because I've got no propensity to be able to bend, bow, turn. It's all the same. It's kind of like walking around the roadblock.
And these came about after, all of them came about after the brain tumor and its surgery.
Well, nobody said my metabolism, that went south. So it's like anything I ate just stuck and stayed with me. So I don't have anything as far as digestive is concerned. Everything just kind of like sticks. It's like the major gland in my head's gone, so all the cells are going, hey, is anybody talking to me? And they run amok every now and again, just do their own thing.
Sharon, you're still on DDAVP quite a bit.
Yeah, I'm stuck with that diabetes insipidus. I wish they'd come up with something other than a nose spray, because I've always got to arm wrestle the pharmacy because they'll take it out of the formularies. And then I'm stranded trying to get the drug company and the HMO to work out the details so that the thing is back. Because it's not like it's ABC, can I take that or can't I take that? It's part of my life. So unless they come up with something new, distribution-wise, pill form, I tried that didn't work and alleviate anything. But anyway, here I am. I just think it's profound that I never was eating like a dozen eggs and 3 loaves of bread for breakfast. I go, at least I have an explanation now for my size and my weight. It was always pituitary.
Yes.
Well, welcome. Thank you for driving all this way to join us. Again, another person who has had difficulties with regulating hormones, even though that if she can't even get the medication, another issue that some of you may face, more so these days with getting growth hormone for adults, but even DDAVP, which is a life-sustaining hormone, is that sometimes you have battles to deal with in terms of your health and battles to deal with the insurance company. There is no new DDAVP that's
expensive. It's $150 a bottle.
Yeah.
So I mean, I go
You
through
use
four
how many
bottles a month, and I hate to get down to like the very bottom because then it's
What happens?
ineffective and-
What happens when you don't take the DDAVP?
Oh, but I end up running around with 2 gallons of water, one in each hand, yelling at people to fill them up.
So
I'm guzzling water like it's out of style.
So for those of you who are not familiar with diabetes insipidus is caused by lack of a hormone that's actually made by the back part of the pituitary gland that controls thirst and urination. And without that hormone, you're constantly thirsty and constantly going to the bathroom.
There's no relief. It's like your body just cannot. It goes into overload.
Right.
Yeah, I had that earlier. I know how it is. It's just you feel like you're gonna die if you don't have water, and you're constantly going to the restroom. It's just terrible. Day and night. I mean, doesn't even stop at night.
Well, I forgot my meds and I ended up at McDonald's with 2 gallons, one in each hand. I said, I gotta have these filled and I gotta have them now. And before I left that restaurant, I'm sitting in the parking lot just tipping that up all the way down.
Right. Some of you may have experienced what's called transient diabetes insipidus, which is a brief episode of diabetes insipidus that occurs right after surgery. That tends to happen depending on the surgeon and depending on how complicated the procedure was, 10-15% of the time. But fortunately, it goes away after a few days, and it's temporary. In some situations where there's enough damage, actually the hormone which DDAVP is an analog of, is made by the hypothalamus. It's made by an area of the brain that's even higher than the pituitary gland. And the pituitary gland just stores it before it's released. So usually diabetes insipidus is a manifestation of large tumors and tumors that go upward and affect the hypothalamus. So
Yeah, they know that that's damaged because on the MRI now it's a gray looking area. So whatever the hypothalamus is in charge of, mine's like damaged, dented, whatever. It's not functioning like it's supposed to anyway.
okay, so we've had it's great because we have a representative of most of the pituitary tumors. But let's continue. Who else wants to share their experiences and what they want to get out of today's meeting?
My name is Lori, and 11 years ago I had a pituitary tumor removed because of Cushing's disease. And after, many doctors defined the Cushing's disease, I was so thankful to have the surgery. And although I was on replacement medicine for a year and a half or 2 years, which was kind of unusual, it's usually not that long, after that, I've been feeling fine. And the good news was, for all of you who have Cushing's, I lost like 40 pounds in 2 months. The weight just fell off. So, that was major, just getting this weight off. So I've been fine for 11 years, and a year and a half ago, I was diagnosed again with Cushing's and a pituitary adenoma. So that's what I'm going through right two opinions from neurosurgeons. One neurosurgeon says he would take out the tumor, although the tumor isn't showing up on any of the scans. We're not sure where the tumor is hiding. And another neurosurgeon said he would just wait until maybe it would grow, or all my other options have run out. So right now I'm on a medicine called ketoconazole to help the symptoms of the Cushing's.
What do you think of that medicine? How
You know
does-
what, I'm doing fine on it. I haven't had, and I've been on it probably for a year, which I'm told that a lot of patients aren't even on it that long. So I haven't had any side effects.
Great.
All my, blood work is fine, like my liver functions because of the medicine. So I just don't know how long I can be on it.
And how high are your levels of cortisol
You
when
know
you're not
what?
on it? Do you know?
They're not really that high. They're, they're higher than normal, but not that high.
And is your ACTH above normal yet, or no?
I think it is. So anyway,
So a recurrence of Cushing's disease in this case, but on the positive side, controlled now, at least to some degree, with a medication. Ketoconazole is a medicine that blocks the production of cortisol. And as those people who have Cushing's disease would know, Cushing's disease is essentially a disease where cortisol is overproduced. So ketoconazole doesn't really do anything to the tumor itself, but it actually blocks the release of the hormone.
May I ask how many years it was after your surgery that you were re-diagnosed with Cushing's?
11. Big surprise.
Yeah.
And that's maybe something Dr. Cohan can talk about a little. We've got a lot of things to talk about, but that pituitary disease is pretty much for life to be followed up on, not to scare people, but just to be proactive with your follow-up. So.
Right. The positive thing, if you can look at it this way, is that hormonal diseases will give you clues. Initially you gained weight, you realize some of the changes that happen in your body, and so if a recurrence happens, and we hope that it never does, at least you get some physical clues. There's Dr. Kelly. How are you?
Thanks for coming.
My pleasure.
Wow.
Most of you know Dr. Kelly, I think.
Oh, absolutely.
Yeah,
Came
this
to
is,
say hi.
this is one of our favorite speakers.
Well, thanks to Charmin, she had a very catchy title, so everybody.
Maybe it's a Charmin to come over the kitchen.
And she forgot to tell Dr. Cohan. Oh, that was minor detail, with me.
Okay. Well, I'm sorry to interrupt. I just wanted to
A lot of these people are patients that you've had.
recognize a lot of
Yeah. And for those of you who don't know Dr. Kelly is the head of the pituitary program at UCLA. He's been doing that for over 10 years, I think, and he's a pituitary surgeon. He dedicates all of his professional life to pituitary tumors, pituitary diseases, research, clinical care.
Dr. Cohen was the former co-head.
I was gonna say.
Decided to go to greener pastures. But we still see him.
Well, there are two favorites, I would say, so we'll have Dr. Kelly in a few months back to do a talk too.
Yeah.
I have a question while he's still here.
Now, keep in mind, he's been in surgery all night, so
Because
he might
he was
not
going to
be.
do the procedure again, but what would be my advantage in having it done again?
You still have a pituitary tumor?
Yes.
So you had, Frank, you had a tumor that they attempted to remove, but it was aborted or stopped because you had complications
Because during
with
the
bleeding.
surgery, yeah.
So he developed a hemorrhage and a stroke, and they aborted the surgery. So I'll let Dr. Kelly answer. From a hormonal standpoint, it's unlikely that another surgery would help you
That's what
with
I'm
hormonal
thinking about,
function.
yeah.
The general thing that we tell patients is that the hormones, there are some exceptions in the case of prolactin tumors and Cushing's disease, but in most cases the hormonal function that you have prior to surgery is very similar to the hormonal function afterwards.
I'm having visual fields done every 6 months
Right.
to track, see if there's any pressure on the optic chiasm.
Did you have radiation?
When?
Did you have radiation treatment?
No.
No.
I had one when I was a child, but that was another tumor, another cancer.
And
it's not growing, it's not causing new visual
Taking
problems, it's not
bromocriptine, basically.
headaches. I mean, if the bromocriptine's controlling it, there's no indication to operate.
Okay.
Right. So the surgery would be to remove pressure if it's causing pressure, if it's growing, and if it's not doing any of those things, then you won't benefit really from having another operation.
Thank you.
Thank you.
Bye. Nice to see you. Okay. Okay. We'll definitely talk about.
I was told that, I just remembered the other thing, I was told I could possibly have growth hormones to increase my energy, but then the cancer crap, and they said you can't even have that.
Right. So
Do you know this fellow, by the way?
We'll talk a little bit. I don't know this particular person, but
He knows you, but anyway, I just wondered who this.
Kind of, since we've got a lot of questions, and we'll
Okay.
probably, does anybody, I just wanted to kind of go back here for a second so we can have an overall view, because you come for a family member, and so that's important to know too, that sometimes our support group has people here that don't have a tumor but come to educate, and you can maybe kind of fill us in a little bit why you come.
My family member is a patient of Dr. Cohan, and it's been better since we're back on medication, but a lot of behavioral issues.
So the support group is good sometimes for family as well.
It's helped me understand so that I can be supportive. It's hard sometimes, but it's been a lot better. Recently, it's been a lot better.
thank you for coming. A lot of times, what we don't realize, primarily as physicians, is that the family suffers as much, if not more, than the patient themselves, because they're worried. They feel that they can't help. Hormones are going up and down.
You don't have any go up and down. Weight loss matters. Flat toast, done over, finished.
And the family is doing their best, and yet they can't help. But they can learn more about the disease and understand it, and know that to some degree you know these are things that we can't control all the time. And just the fact that you're there for your family member and you listen and you care is sometimes all that you can do, and that counts for a lot. I think we have questions from most of the representative tumors.
Did you have anything pressing, honey? Did you want? Or is there anything that was additional?
I just had a macropituitary adenoma, which I heard a lot of Cushing's disease and some other things. I don't know if that was particularly addressed.
For a macroadenoma, yeah. And do you have hormonal function now?
You know, it really profoundly changed my life, and I'm still. It's been almost 3 years, and I'm still kind of on the upswing, but it's been a really slow road. Right after surgery, I had to be on thyroid medicine for a year, which may or may not have been related, and I had always been healthy up till, the start of the symptoms, and then that was a gradual thing until I had surgery. So it's kind of like a hill for me. I think I'm continuing to get better, but I'm really proactive too with my own kind of investigation. I'm real fascinated with the whole endocrine system, and I'm always trying to do stuff to make it better. But it did affect my life, and in a lot of ways.
Was your pituitary tumor secreting any hormones?
Gosh, I don't know. I had amenorrhea, but I didn't lactate. I did have an enormous amount of stress. I mean, the stress that I had was compounded by, I think, my condition, and also just the frustration of not knowing for a long, long time what was going on. So, I don't know.
Okay.
I felt like they're all out of whack.
But you had surgery for it.
I had surgery. It'll be 3 years in October.
Okay. So probably another non-functional tumor, meaning that it wasn't necessarily making a hormone, but still causing lots of hormonal problems. Amenorrhea is the medical term for lack of menstrual periods. So that's one of the things that you presented with, and certainly one of the signs that could clue in a doctor to a pituitary problem. So maybe we have as I've heard everyone, we have representative patients with essentially every pituitary tumor. There's one form of the pituitary tumor that we didn't have a patient with, which are tumors that release thyroid-stimulating hormone, but those tend to be very rare, and generally you need to have a group of 100 pituitary patients to have one patient with that particular tumor type. But we've had patients with prolactinomas, with non-functional tumors, Cushing's, growth hormone tumors, which would be acromegaly. So first, just to backtrack a little bit, everybody here that spoke so far had a pituitary tumor. And the first question is why? Did anybody ask themselves, why did you have a pituitary tumor? So you've asked yourselves, you asked God or whoever you believe in, you asked your doctor, and nobody knows. And I've done these meetings now several times, and I'm hoping that one day I'll be in front of you and we'll be able to tell you what caused the pituitary tumor. What is sure is that none of you did anything that brought up a pituitary tumor. To our best understanding, there is nothing that we know that causes the formation of pituitary tumors. With certain tumors, like the prolactin tumors, there was a period of time that it became popular to think that birth control pills may have caused them. But now we essentially know that that's not the case. So it's still a black box. It's still very mysterious as to why pituitary tumors develop. As we've heard, pituitary tumors can arise from any of the cells in the pituitary gland. The pituitary gland, although it's a very small gland, it is compartmentalized, meaning that it has areas or cells that are specialized to release a particular hormone. So for example, some cells are engineered to make growth hormone. Some cells are engineered to make ACTH, which is the signal for cortisol. Other cells make the hormone prolactin, which is primarily important in lactation. Other cells make the signal for thyroid hormone. Other cells make signals for the production of estrogen and progesterone in women and testosterone in men. Other cells in the back part of the pituitary store antidiuretic hormone, which is the hormone that controls thirst and urination. So within the pituitary you have separate compartments. Each cell has its own function, and each of these cells can all of a sudden become tumorous. And when they become tumorous, they start to release the hormone in excess. So normally hormones are released in a coordinated fashion, very tightly regulated. If a person comes in and takes a little bit of hormone as a medication, the pituitary gland senses that and decreases the production so that the net balance is always preserved. So things are released in a very coordinated fashion, but when a tumor develops, it's essentially one of these cells going haywire, replicating, and then becoming a visible growth. In some of the cases, the tumors could be very small, like the Cushing's tumors, which are sometimes so small that you can't even see. In some cases, the tumors are so big that they may all of a sudden bleed and cause visual problems, and then you can have any size in between. So it turns out that some tumors tend to be smaller and others tend to be bigger. Part of the reason why some tumors are bigger are because there's a delay from the time that the tumor developed to the time when it was diagnosed. If you listen to the symptoms that some of the people in this room had, they're very, very different. In medicine, we call it very nonspecific, which means that hundreds of different diseases could have potentially caused, for example, nausea. Many different diseases can cause weight gain. Many conditions can cause amenorrhea or lack of periods. So the symptoms tend to be not specific. It's not, for example, oh, I had this symptom, so you have Cushing's disease. And that's what makes things difficult. So symptoms can be very, very variable. The first tumor that we discussed was a prolactin tumor. That's the most common pituitary tumor. These prolactin tumors, by releasing the lactation hormone in excess, cause problems with menstruation, problems with sexual function. It can cause lactation both in men and women. So men who have prolactin tumors can begin to have lactation as well, which is a very scary experience for a man. The good news with prolactin tumors is that for the most part, they're very, very responsive to medications. And that's the typical tumor that is treated with medication rather than with surgery. Although in some cases surgery is done, but for the most part medications are used. Go ahead.
You mentioned sexual function. What?
Well, when prolactin goes up, libido goes down. So it's an anti-libido hormone. The other thing with prolactin is that as the level goes up, sexual hormones go down. So that's why when the prolactin level is elevated, estrogen levels go down, periods stop. In men, testosterone levels go down. They can have hot flashes just like women. Men can have sexual erectile dysfunction. Women can have vaginal dryness, a lack of interest in sex, pain during sexual intercourse. But as the good news is that as the prolactin level comes down, most of these hormones then come back, and sexual function generally returns to normal. When a hormone is overproduced and an intervention is done to bring the hormone level back to normal, whether it's for prolactin tumors or whether it's for Cushing's patients, there's a big change. Your hormone levels go from being very high to very low in a relatively rapid amount of time, and this is why sometimes people feel some symptoms, and it's a difficult adjustment period. The most difficult is for the Cushing's patients because cortisol, the lack of cortisol can cause so many different symptoms. In addition to the sexual problems, cortisol problems can cause the issues with energy level, with weight, with nausea, with body aches and pains, you name it. Cortisol is a life-sustaining hormone, and any fluctuation in that can have fairly serious symptoms. In your situation, is the prolactin level now controlled?
That's kind of the air. I haven't been able to have some lab work done for financial reasons, but I just recently became employed with a company that offers medical benefits. So within a couple months, I'm going to hightail it to the laboratory and want to
Good.
see you.
So for a patient with a prolactin tumor, the most a very important lab test is just measuring the prolactin level. The good thing about that is that it's just a simple blood test. Some of the people who've had Cushing's syndrome or Cushing's disease, whenever you need to have a test for that, you need to either collect 24-hour urine samples or have suppression or stimulation tests. For prolactin tumors, usually a blood test for prolactin will suffice. And if the prolactin level is elevated, there are medications to help control it, and when the prolactin is controlled, many of the symptoms go away. When the hormone is brought back to normal, these symptoms don't return back to normal overnight. It may take months. So in a person who had a prolactin tumor and the tumor is controlled, it may take several months before their periods come back, even though the prolactin is normal, because the body needs some time to, for the glands to wake up again. And that's an important point, is that you would think, okay, well, the tumor is removed, the problem is eradicated, the overproduction of hormone is now gone as soon as the surgeon removes the tumor, but why is it that you have that year or year and a half or however long it is? On average, it's about a year to 14 months. But some people, the return of function occurs earlier, and then some people later. But why does that happen? Well, I'm going to just draw a cartoon of the pituitary gland. And as we talked about, the pituitary gland, you can think of it as having different compartments where there are different cells that make different hormones. So in the case of Cushing's disease, you have the area, the cells that normally make ACTH. And this is the area that's affected. ACTH, again, is a signal for the release of cortisol. So in Cushing's disease, what happens is that one of these cells goes haywire. So normally you have many cells that make ACTH, and they're making it in a very regulated fashion. But when a tumor develops, one of these cells decides that it really is fond of itself, so it wants to replicate. So it goes from being one cell to being 2 to 4 to 8 to 16 to 32 to millions of cells. So now all of a sudden this guy has replicated, and it could grow to a point where actually you can see it on an MRI, or it could be so small that you can't see it on an MRI, but it's still a collection of thousands or if not millions of cells. So now what's happening is that this cell is overproducing signal for ACTH. So rather than making a normal amount of ACTH, you're making 100-fold or 10-fold, whatever, higher amounts of ACTH. So the cortisol levels go up, and that's why the weight gain happens, the diabetes can happen, the high cholesterol can happen, the osteoporosis can happen. These are all conditions that can happen when cortisol is overproduced. So now you're lucky enough that this Cushing's disease was diagnosed, and now you have surgery. And so the surgeon, if the surgeon is a good surgeon, he or she will come and take this tumor out and just remove the tumor and remove and allow the remainder of the gland to stay intact. So now that the tumor is removed, what happens is that these other normal pituitary cells that were making ACTH are now asleep, because they saw high amounts of ACTH before, and when they saw that they behaved in a normal fashion, they shut down. They said, there's lots of ACTH coming along. The bad guy, the tumor, was making lots of ACTH, so these guys went to sleep. And this is where the problem comes, is that as soon as this tumor is removed, these other guys are all asleep, so now the cortisol level goes down to 0. So what's happened essentially in a period of a couple of hours is that cortisol levels have gone from being several-fold above normal to essentially being 0, and this is why we call it the roller coaster. So within a couple of hours or days, the cortisol level has plummeted, and this is where all the symptoms come about. These are symptoms of lack of cortisol, like the nausea and the body aches and feeling tired and not being able to get out of bed. Cortisol is the get out of bed hormone. It's the hormone that gives you the kick so that you can get out of bed and start your day. Without it, you just want to stay in bed the whole day. So the fatigue, the mood changes, the body aches, the nausea, not having any appetite, and that's from the lack of cortisol. Now, an endocrinologist comes along and says, well, the cortisol level is now very low, let's give you back cortisol. So we give back cortisol in the form of prednisone, some of you may have been on, or hydrocortisone, or Cortef, or a variety of different names for it. And now we try to give back cortisol in the right amount. The problem is that it's difficult to give the cortisol back in the right amount because there's no blood test that says the cortisol level is right or not right. We have to go by symptoms. If a person is having a lot of nausea, we may think that the cortisol is not enough. We may give them more. If we give too much, what happens? Cushing's develops again. This time, Cushing's induced by the doctor, meaning that too much cortisol is given now from an external source, by a medication. So there's a tight balance, and it's for that reason that it's very difficult to get the hormone right. The good news is that within a year or so, these cells that were suppressed begin to wake up again. And as they begin to wake up, the prednisone can be stopped, and the pituitary gland regains the ability to release the signal in a regulated fashion. And this process takes about a year, sometimes a little bit longer.
Does the medication facilitate those cells to be reactivated?
No. In fact, if anything, if too much of that medication is given, it will suppress them again. Because these normal cells are extremely sensitive. If they see too much hormone coming in, they will get suppressed again. So what we try to do is we try to underdose people with prednisone, slightly give less than the body normally makes in order to provide a stimulus for them to wake up again. But if we do that, then of course, under-replacing causes people to be more uncomfortable.
May I just comment on that, and I don't know if this pertains to your question. but I had felt so horrible because of the behavioral problems. That was, I think, the most awful part before the surgery for me. And within 24 hours of the surgery, my head had felt improved. I don't know quite how to say it, but before that, it had just felt incredibly crowded. I had intractable high blood pressure. Maybe it was the blood pressure. But in my case, I am so happy to have those cortisol levels down that it doesn't even matter to me that every part of my body aches. I was really happy to hear you say that because I just thought I couldn't figure out why I ached. And the physical symptoms are so worth it in order not to just feel this incredible rage, which was not my personality. And it was just awful. And I don't ever want to have that come back. And I will be, I will take the physical difficulties over that any day.
Right, and that's, you said that so well. You said that so well. And as physicians, we actually rejoice when the cortisol goes to zero. When Dr. Kelly calls me and tells me that Pejman, I operated on Mrs. So-and-so, and the next day the cortisol level went down to zero, even though the patient is feeling horrible, a big smile comes on my face, and I'm happy to hear that, because that's a sign of a I tend to be careful using the term cure, but a remission, because as you've heard, sometimes these tumors come back, and fortunately it's uncommon. But there is definitely a risk of the tumor recurring, just for the same reasons as we don't know what caused them to begin with. In a person who's predisposed and had it come about to begin with, it can resurface even after a successful surgery. So we monitor people and make sure that every year, every other year, they come back and we run the tests. We listen to them to see if they have symptoms to make sure that things haven't recurred. You had a question?
What does cortisol have to do, or does it have anything to do with the adrenal glands?
Yes, that's a good question. So cortisol is made by the adrenal glands. So when I drew this cartoon that ACTH is made by the pituitary gland, the signal, what's made by the pituitary gland is ACTH. And ACTH is the signal that stimulates the adrenal glands to make cortisol. So that's an important point, that the pituitary gland doesn't make cortisol. It makes the signal for cortisol. So cortisol actually comes out of the adrenal glands. Now, in the situation we had where Cushing's syndrome came back, but now it seems to be a little bit mild. It's not as severe as the initial situation. The tumor can't be seen. What can be done is to give a medicine to block the production of cortisol, and that medicine, ketoconazole, is working down here. It's not doing anything to the ACTH or the tumor. It's just blocking it from acting on the adrenals to release cortisol. So all that ketoconazole does is controls the cortisol level. It doesn't actually control the tumor itself, and that's why it's sort of a Band-Aid on the problem until something definitive is done, until either the tumor declares itself and is visible, or the surgeon feels comfortable in operating. So that's an important point, because most of the hormones, with the exception of growth hormone and prolactin, all the other pituitary hormones are just signals for the other parts of the body or other glands to make their hormone. So we discussed ACTH, but in the same way, hormones called FSH and LH, which are made by a different part of the pituitary gland, are the hormones that then work on either the testes or the ovaries to allow these glands to make their hormone. And in the same way, a hormone called thyroid stimulating hormone stimulates the thyroid gland, which is a butterfly-shaped gland in the neck, to make thyroid hormone. So this is why the pituitary is called the master gland, because it is the gland that sends signals for the other glands to work. Prolactin and growth hormone are actually made by the pituitary as the actual hormone. It's not a signal that goes to another gland to release the hormone, but prolactin and growth hormone are released directly from the pituitary gland as the hormone itself. antidiuretic hormone, if this was three-dimensional, would be the back part of the pituitary gland called the posterior pituitary, which is actually just a storage area for antidiuretic hormone. Antidiuretic hormone is actually made up here in the hypothalamus. Now, the people who had Cushing's disease, all of you initially at least had surgery. Is that right? Because for tumors that make ACTH or for Cushing's disease, really surgery is the only thing that could cure that condition or put it into remission in the long term. There is no medication that could be given to make this ACTH-producing tumor shut down. We talked about ketoconazole as a medicine to block the hormone at the adrenal level, but it's not going to control the tumor. So Cushing's disease is a surgical disease, meaning that if you want to have any chance of a long-term remission or a potential cure, the surgeon has to remove the tumor. With prolactinomas, which we discussed earlier, those tumors are very sensitive to a medication called Dostinex or cabergoline, or older medicines called Parlodel or bromocriptine. Those medicines tend to shrink tumors that make prolactin and also lower the prolactin level. So that's why prolactinomas are generally felt to be medical diseases that medications can help and not surgery. So most people who have prolactin tumors are offered a medication, not surgery. There are exceptions, but for the most part, prolactin tumors are.
I just have a question about that, because that's what I just heard months ago that I have a and I may find an endocrinologist and I'm up in Santa Barbara. But
We have some good ones in Santa Barbara.
Good.
Yes.
Okay. What I'm wondering is why medication versus surgery. I don't even like taking Tylenol particularly, so I'm trying to what would be the benefit of medication over surgery?
Okay, it's a good question. So I mentioned that for prolactin tumors, which are a special pituitary tumor, medications could be extremely effective because you need to, if you take them, it controls the tumor, it shrinks it. Actually, it could shrink it to the point where it's not visible anymore. The caveat is that in general, the treatment with that medication is felt to be indefinite or lifelong. So in a person who may not want to have to take a medicine for the rest of their life, that would be one of those situations where potentially surgery would be an attractive option. And you know, surgery is not without risks, and so that's why if a disease could be potentially controlled with a pill that you take once a week or twice a week, most people would prefer that, but not everyone. Some people have had complications from pituitary surgery. When the surgeon comes, I drew this picture of a very nice carving out of a tumor. That's Dr. Kelly doing that surgery. Sometimes when the person comes and tries to remove this tumor, because pituitary surgery is extremely difficult, what you're operating on is through a narrow field through the nose with microscopes, tiny little instruments that are fed through the nostril, and this entire picture is 1 centimeter, this big. So you need to have somebody really experienced do your surgery, because if they come and the angle of the blade or curette is a little bit off, well, you're going to take off half the pituitary, and start to affect other parts of the pituitary that make other hormones. So one of the risks of pituitary surgery is that in an attempt to remove the tumor, you also remove normal pituitary gland, which is important for regulating the other hormones that we discussed. So you need to have, if you decide to, so this is one of the risks of pituitary surgery, is injury to normal gland. The other risks to pituitary surgery is that there are visual nerves that run right above the gland. It's called the optic chiasm, or the chiasm means a coalescing of structures, and optic means visual. So a coalescing of all the visual nerves, a crisscrossing of visual nerves occurs right above the pituitary gland. And again, if the trajectory to the gland is a little bit off, this optic chiasm can be injured and cause visual disturbance. Two important blood vessels flank the pituitary gland. Those are the internal carotid arteries. They're the main arteries that supply the brain with blood. So if you're coming to the pituitary and you slip and you hit the internal carotid artery, then you have a stroke. Right? Is that what happened, Frank, to you? You had a stroke?
Actually, no. The surgeon said he opened the bottom of the pituitary gland, and that's all of a sudden the blood just rushed out. That's when they just decided, rather than trying to stop the bleeding, just to stop the surgery altogether. Well, actually stop the bleeding instead of trying to control my blood pressure. It bottom, sort of bottomed out. So.
The pituitary gland normally doesn't bleed, so it's possible.
Really?
Unless the pituitary...
Because my surgeon seems to have the idea that they burst occasionally.
Occasionally they can.
Occasionally
they can, but if you have a hemorrhage that results in, you had a stroke actually, or did you have paralysis or weakening of the side of your body?
Yes.
So generally that's due to injury to the artery that feeds that part of the brain. But in rare cases, pituitary glands can also hemorrhage, and they can all of a sudden bleed. So that's possible too. That's a lot. Normal pituitary surgery, you lose 20 or 30 milliliters of blood, if that much. It's generally not very bloody. So getting back to what we were discussing is that pituitary surgery is not without risks. In experienced hands, it's safe, but there are very important structures. The field is very narrow, and so you need to have an experienced surgeon, and that's the main drawback of surgery. So taking a medicine twice a week has none of these risks, but it also is an inconvenience, and you need to take it for the rest of your life. So the decision to take a medication for a prolactin tumor or to have surgery oftentimes becomes a personal decision, and everybody, if you're seeing doctors that are good, will give you all the options, and then you can make an informed decision.
What are the types of medication that you take for?
There's only one type. These are called dopamine agonists, but underneath that there are several different brands or different preparations.
Has there been any research as far as natural medicines outside of the typical medical?
More of a holistic type.
No research. No published research. Yes. On a prolactin tumor? Rarely. Why? So one of the treatments, so we talked that medications could be used for certain tumors. We talked that certain tumors are treated primarily with surgery. I didn't talk about the growth hormone tumors or the acromegaly, but those are tumors that are primarily treated with surgery as well, although medications exist for that too. But certain diseases are treated surgically, certain diseases are treated medically with medications. How about radiation? Well, radiation is used only if either of those treatments don't work. So it's never, in my opinion, almost never a first-line treatment. So if, for example, a person has a large tumor and most of it is removed, but there are some parts of the tumor that are either inaccessible or dangerous to remove through using surgical blades and things like that, then as an adjunctive therapy, as an additional therapy, radiation can be given. So to treat a tumor first line with radiation is uncommon, and I'll tell you why in just a second. But two questions came up, so let's.
I don't want to interrupt. I just had a question because you just mentioned that during the surgery, other parts of the pituitary could be damaged, and would that be definitely the following, would that be an underproduction of a hormone, or could that also cause an overproduction? I'm just trying to find out if I misdiagnosed me in the beginning, or if this problem that is occurring now is maybe due to the surgery.
It's always underproduction.
Okay.
So if inadvertently a part of the pituitary gland is removed, then that would result in lack of hormone production.
All right. So that I must have had it before.
So if you in your situation you had high cortisols afterwards or some other
Just
hormone.
now, 5 years after.
5 years
the operation.
afterwards, it's unlikely that the surgery caused the cortisol levels to go up.
Good to know.
So that would be it's usually hypopituitarism or underactive pituitary.
I was wondering, what are the risks of getting pregnant or being able to stay pregnant or a normal pregnancy on medicines for either Cushing's, like ketoconazole, or medicines for prolactin?
Okay, good question.
Can you get pregnant? Can you stay pregnant? Will the baby be okay?
Okay, we'll talk about that. Let me just finish. The question was posed about radiation for pituitary tumors, and I said that we usually don't use it as a first line. We use it as something in case other treatments fail. And why is that? Why is it that radiation is not a first line treatment? Because you may think that that's a good thing. You know, nobody is cutting on you. You're not taking any pills every day. It seems to be, bloodless surgery. Why isn't it offered more? Well, the problem with radiation is that no matter how focused that beam of radiation is directed at the particular tumor, almost always some of the radiation beam trickles around normal gland. So even though that you focus the beam at the center of this tumor, there's going to be some fall off, and some of the normal gland is going to get irradiated. And so what happens if normal gland gets irradiated? Hypopituitarism, underactivity of the pituitary gland. So the good news is that newer methods of radiation or radiosurgery tend to be much more precise, but almost always you're going to get, with time, decreased in other hormonal function. It could be delayed. When you get radiation, it may take years, decade, for the other hormones to go down, but ultimately, with time, they do become low, and then they need to be replaced. Now, the exception is that if you have a tumor, as I mentioned, if you had a large tumor that was like this, and the surgeon removed as much of it as they could, but they couldn't remove this part that's around the artery because there could be bleeding, and this remaining tumor is far away from the normal gland, well, then it would probably be safer to irradiate that because it's much more distant than normal tissue, and so it won't be in the radiation field. But for the most part, one of the main risks of radiation is injury to the normal gland, and for that reason, it's a second-line treatment. So pregnancy and pituitary tumors. First of all, in people who have pituitary tumors that are untreated, it's very difficult to get pregnant, right? So people who have Cushing's syndrome, or people who have growth hormone tumors with acromegaly, or growth hormone or prolactin tumors, usually one of the features of that is amenorrhea, which is lack of periods, and which comes with infertility. So untreated pituitary tumors can cause infertility, and therefore we need to do something to the pituitary tumor to control it for fertility to be restored. Now, let's say that we do that with a medication like the medications for a prolactin tumor. It turns out that some of the medicines that have been around for a long period of time have been used during pregnancy and found to be safe. So there are some medicines that you can take for prolactin tumors, some of the older medicines that, because of the fact that they've been around for 30 years and doctors have tried them in pregnant people, we now know in retrospect that they're safe. Some of the newer medicines that have not been around as long, we don't know the answer to it. They're felt to be safe in patients who've gotten pregnant on it, but we don't know the exact answer. And in fact, in this day and age, research is so difficult that it's very difficult for a hospital or a university to approve research in giving a medication to a woman who's pregnant. So there may never be an actual study in which some pregnant women are given a medication and some pregnant women are not, and you see whether the ones who got it have more birth defects. It's very hard to carry out research like that, so we may never know. But the older medicines for prolactin tumors are felt to be safe. The problem is that the older medicines cause lots of side effects too, other side effects like nausea and vomiting. So it's difficult. So what we try to do is try to give the medication, control the tumor, and hopefully at the time that pregnancy occurs to stop the medicine and follow that patient quickly with the case of the prolactin tumors. With the question with ketoconazole, the answer is no. Ketoconazole would not be safe in pregnancy because ketoconazole would inhibit the production of a very important hormone, probably in the baby as well, and it's just if you look at ketoconazole, it would be contraindicated in pregnancy. So some medicines for some tumors would be okay, other medicines would not be. In general, we try to stop any type of medicine as soon as pregnancy is confirmed so that we don't expose the fetus to that. Did you have any other questions about bromocriptine, which is otherwise known as Parladel, or an older medicine that controls prolactin tumors that have been around for 30 years or so, and therefore it's been tried in pregnancy and found to be safe.
And then with the surgery, if you do it surgically and the whole tumor isn't removed, just a portion remains, would that then regrow?
Yes. So if a surgery is incomplete, then the remaining tumor can grow, and so some other treatment medication would need to be given. Yes, you had a question?
I was just going to say my experience with pregnancy was that I had a stillbirth at 9 months, and I had a pregnancy that went south on me at 5 months. But everybody thought I had gestational diabetes, and that was the underlying factor. So I ended up with Dr. Ivanovic in Santa Barbara at Samsung Clinic. She held all of my blood sugar numbers at a normal range, and I've got a 15-year-old. But with the surgery with my pituitary, they looked at me and they went, "And you have a child?" And I go, "Yeah, evidently my ovaries are working independent of the tumor and the pituitary. I don't know any other way to explain it."
Right. That's certainly a very exceptional case because fertility is the ultimate test of the pituitary gland, meaning that if the person comes to me and was worried about a pituitary condition but tells me that they were pregnant last year, it makes it hard for that person to have a pituitary problem. It's not impossible, as you just heard, but fertility and the hormones that regulate ovulation, sperm production are made in such a very delicate, intricate way that any sort of hormonal perturbation, tumor, will tend to disturb that and cause infertility. So that was good. Gestational diabetes probably occurred because people with growth hormone tumors or acromegaly are more prone to have diabetes.
Well, that's why I was treated with 80 units of insulin twice a day to try to keep everything in check. And then when Dr. Ivanovic was called when I was running around to the Mayo Clinic, Rochester, Minnesota, she goes, "Hey, I think this just might cure your diabetes." I go, "Yeah, if this tumor doesn't kill me first."
Right.
So that was the upshot of that.
So one of the important points, another important point in this is that pituitary tumors can cause other diseases that are common in our society. So pituitary tumors that cause production of cortisol in Cushing's or acromegaly can cause diabetes. And so and if that tumor is controlled, then the diabetes generally goes away. Cushing's tumors can cause osteoporosis, which is another common disease. A lot of people have osteoporosis. People with acromegaly or Cushing's disease can develop hypertension or high blood pressure. So these hormones not only do control glands, but have systemic effects, have effects on the rest of the body, and can cause other diseases. Why is it that a tiny tumor that causes Cushing's disease, that's so tiny that you can't even see on MRI, kill a person? Well, because it can cause high blood pressure, it can cause diabetes, it can cause heart disease, things like that, because the hormone affects other parts of your body. So this is the reason why it's important to go ahead and treat it even if a tumor is small.
I had a quick question about the FSH and LH.
Right.
Would you test that on me? I mean, my endocrinologist is doing both. Why would he do both? Why wouldn't he just do test, check my FSH and forget the LH?
Well, I clumped FSH and LH together, but they actually have slightly different effects. So FSH stands for follicle stimulating hormone. it's a term that's more applicable to women because it is the hormone that helps in development of the follicle, which is the egg. And so FSH is mostly involved in in the formation of sperm and follicles. LH is mostly responsible for the formation of testosterone. And LH is also the hormone that is released for a woman to actually ovulate. So they have some different effects. In general, we measure them both together. I clump them together because both of them ultimately affect gonadal function, but they have different roles. So let's look here. We talked about some of the difficulties with the recovery from Cushing's disease, the bittersweet sort of period of a year or year and a half where things are getting better but you feel poorly, and then the monitoring that is essentially lifelong. What is some of the risks of recurrence of pituitary tumors once they've been put into remission? The numbers vary, but anywhere in the literature, anywhere between 5 and 15% or so. So they can come back, and we need to be on the lookout for that. I want to talk a little bit, address a little bit the issue of hormone replacement, or should we take a break, or should we keep on going?
Jerry, how are you doing?
Okay.
Yes, you.
What would you recommend as far as follow-up? How were you saying to be tested once every year, every other year, or?
Good question. So we generally, in a person who's had a treatment for a pituitary tumor, let's just talk about that treatment being surgical. So for Cushing's disease, for acromegaly, for a prolactin tumor that was treated surgically, not medically, for a non-functional tumor. We didn't really talk about non-functional tumors, and maybe I'll talk about that as well. But for these tumors that are treated surgically, the follow-up is usually 3 months, the first follow-up with another MRI, and then annually thereafter for 5 years. With an MRI, with Cushing's disease, with growth hormone tumors, with prolactin tumors, the blood test and the laboratory tests are just as good as the MRI.
Because so often with Cushing's, that doesn't
MRI is
show up
normal,
on the MRI.
right? So we generally do a 3-month MRI in everyone, and the reason for that is because the surgeon likes to make sure that the anatomy is okay and the gland looks okay. But for some of the tumors that make Cushing's, that cause Cushing's syndrome or acromegaly or prolactin, you can just measure that hormone and it would be even more sensitive than the MRI. So some form of testing, whether it's an MRI or hormonal testing at 3 months and then at a year and then annually for about 5 years, and then the frequency can be decreased. Of course, we always tell patients to remember and look out for symptoms. If menstrual cycles become irregular again, then we need to evaluate them again. If all of a sudden 30-pound weight gain occurs, then they need to be evaluated earlier. But very close follow-up for 5 years.
Does everyone have symptoms when they have a pituitary tumor? Because I had no symptoms.
Good question.
It was an accident when they found me, because I had fallen off a draftsman's chair and hurt my back, and also my neck hurt. So they took an MRI of my cervical spine and my lumbar spine. The cervical spine, they went up far enough because I was complaining of a bad headache, and we saw a dark spot on that. And that's when they recommended I get a dedicated brain MRI. So I didn't know of any symptoms.
So you didn't have any symptoms.
It was symptoms per se.
So actually, lots of pituitary tumors occur in people in the general population that are asymptomatic. Now it's hard to understand. Asymptomatic is a very difficult term because if you take a person and you start asking them questions, you'll ultimately find some symptom. If you in medicine we do what's called a review of systems, where you ask a person comes in with a specific problem, but you ask them about their whole, about their eyes, do they have headaches, do they have neck pain. So if you do a complete review of systems, ultimately you may find a symptom, but in general asymptomatic tumors can occur, and in fact, if you do MRIs on 100 people that are quote-unquote asymptomatic, you'll find that about 15 to 20 of that 100 will have a small pituitary tumor. But the tumors are generally small, and they're not producing a hormone. So yes, asymptomatic tumors occur because those studies have been done. And they've done MRIs on hundreds of people that are volunteers that are healthy, and we do find there's about a 15 to 20% rate of tumors.
Before I had any x-rays or anything, they looked at my hands and they thought, well, I have unusually large knuckles, and so they thought that might be related. So I don't know.
Right. So the pituitary tumors can be asymptomatic. There's a high rate of what we call incidental tumors, meaning that you do an MRI for one reason, and you end up finding a pituitary tumor, which was the case that you had. But in your case, the tumor was big, right? Ultimately,
Yeah,
2 to 3 centimeters. So the criteria between small and big is about a centimeter. So anything above a centimeter is considered a large tumor, and so ultimately it probably would have caused you to have some symptoms. But so the incidental rate of 15 to 20% is mostly for smaller tumors.
People go through their whole life without having any symptoms.
Yes, absolutely. So it's interesting that in general, tumors that are small tend to stay small. And if a person has a small tumor that is not hormonally active, they can have it for the rest of their lives and then die from some other reason. So, and we know that from autopsy studies, where autopsies are done for people who've died for other reasons. And again, in those series, 15 to 20% of people have small pituitary tumors. Now, if you look at those studies, though, and you stain the tumor for the hormone, you try to look at it, a lot of them will stain for prolactin. So here comes the question, was it really asymptomatic? You know, again, if you ask that person in detail, did you have sexual problems? Were your breasts getting bigger? Were you having some trouble with fertility? You know, those may have been symptomatic.
Would you still medicate someone that's not having any symptoms?
Well, these people, no, you wouldn't. You wouldn't. And these people that died for an autopsy obviously didn't get medicated. If you do an MRI and you stumble upon a pituitary tumor and you do all the tests and they're all normal, then you wouldn't treat them with anything. You would follow it, though, to make sure that it doesn't cause a problem later. The non-functional tumors we need to talk about is that these are tumors that don't overproduce a hormone. Remember, in the pituitary gland, there are cells that make different signals for hormones. There are also cells that are just supportive and are not really releasing any type of a signal. And those cells could also become tumors and replicate and grow. And the hard part with those tumors is that since they're not making a hormone or a signal, usually they don't go detected until they get very big. You know, a person who has a prolactin tumor starts lactating when they're not pregnant or when it's not after delivery, and so that's a signal. But if these tumors are not making a hormone, then there's no physical symptom until the tumor grows and grows and grows, and then starts to hit the visual nerve, and then the symptom is visual disturbance. Often the visual disturbance is what we call a visual field defect, where you lose peripheral vision, because these crisscrossing of nerves control your peripheral vision. So non-functional tumors generally present with either visual disturbance or headache, whereas tumors that are making a hormone, usually you'll have some manifestation of that overproduction of the hormone. Yes?
Doesn't that, I know, I saw my MRIs and my tumor, I think, encompassed the pituitary gland. It was about 1.5 centimeters. And I did have some visual difficulty. But doesn't that block everything else from happening? Doesn't that affect just like all the other?
Yes, if the
because
tumor...
they can't really go through that or be...
Absolutely. Absolutely. So if the tumor continues to grow and grows big enough, it can actually put pressure on the areas of the pituitary that are supposed to release the appropriate signals. So it could cause what's called mass effect, meaning that it just puts so much pressure that the cells that normally make ACTH can no longer make it properly, or the cells that make growth hormone can't make it properly. So it could cause pressure and cause underactivity of the pituitary gland. It could also cause pressure and cause the prolactin level to go up. Anything that causes pressure in the pituitary gland can also elevate the prolactin level. So yes, if a tumor grows big enough, it can certainly cause these other cell types of the pituitary gland not to be able to function and become underactive.
Now that you mentioned, I do remember the headaches for years.
You had headaches for years, and generally, a tumor that's a couple of centimeters is going to cause headaches because the pituitary gland is covered by a sheath, and that sheath has nerves around it, and if it expands, it causes pain. It causes the perception of pain or headache. So with a tumor that's a couple of centimeters, visual disturbance can occur, headaches can occur, and loss of pituitary function because of pressure on the normal gland can occur as well. But generally that occurs when the tumor is large and putting enough pressure.
So basically, how large is the pituitary tumor?
Not much bigger than a centimeter.
Oh, 1 centimeter. So mine measures 2 by 3.
So it's
actually
twice the size of the normal gland.
I'm just gonna, normally our meeting goes till 8, but.
We can go longer if you
Can
want.
we go a little longer? Is that
Yeah.
gonna be okay with you?
Whoever
or-
wants to take a break and have something to drink, you're welcome to, and we'll continue though.
Yeah, but feel free to, if anybody needs to move around or use the restroom or something, we can kind of do that now, if that's okay with everybody. And then we'll go ahead and try to get some questions from people that haven't had a chance to ask. Okay?
Yes, we have a question.
I have a large tumor similar to yours. It's the size of a robin's egg. That's the way Dr. Kelly described it.
Size of a
robin's egg.
Okay.
And it's, from what I saw in the MRI, it's squeezing against my pituitary gland. And so I have high prolactin.
right.
But there are some symptoms that I have and some symptoms that I don't. And I'm wondering if they mimic, like I can, something sounds like Cushing's disease, but I don't have Cushing's disease. I mean, is that a possibility? My field vision is fine. The peripheral's fine.
Right.
And I don't have the secretion. That hasn't happened. I have amenorrhea, but that's kind of expected. I just wonder if there's anything else that could be similar to Cushing's that I don't have. Or
Okay,
you have.
it's a good question. So you have a relatively large pituitary tumor. What was the symptom that made you go to the doctor that ultimately you were diagnosed with a pituitary tumor?
No energy, the lack of a period.
Okay.
Mainly that, and
Okay.
weight gain.
And weight gain.
Dr. Cohen, I had a question that kind of
Sure.
dovetails that. Do the hormones are they always produced independently of each other if there's a problem? Sometimes is there something wrong with the pituitary that it would be, there'd be a suppression or an elevation of different hormones?
Yes, absolutely. So I made a very simplified model here, but it becomes much more complex. For example, overproduction of prolactin shuts down the production of LH and FSH. Overproduction of ACTH shuts down the production of growth hormone. So there's interrelationships as well. Sometimes tumors are co-producing, meaning that a tumor can release prolactin and growth hormone, or ACTH and prolactin. So I made a very simplified cartoon. This looks very complicated now, but there's a lot of what we call crosstalk. Hormones are not released by themselves, but they affect other hormones. Another example is a person who has low testosterone and low growth hormone. Sometimes by replacing testosterone, their growth hormone levels improve too. So there is interactions. Now, with your question, I think one of your questions was that some of your symptoms seem to mimic other tumors. You were told that your tumor doesn't produce any hormone necessarily.
Yeah, it's just high prolactin.
Just high prolactin. Well, high prolactin can occur from any tumor that puts enough pressure in the pituitary gland. So you don't necessarily need to have a prolactin tumor to have a tumor making prolactin to have an elevated prolactin level. Let me say that again.
Okay.
A high prolactin level can occur because the tumor is actively releasing prolactin, or it can occur because there's pressure in the pituitary gland, and that pressure results in the release of prolactin. And that's an important distinction to make. Let me redraw this so that we can get this point clear, because this point, if it's not understood by your doctor, could result in unnecessary surgery. Okay, not by Dr. Kelly, but if it's not understood, because as I said, how do you know then what's going on? If a prolactin level is high, I said that either it could be due to a prolactin tumor or it could just be due to pressure in the pituitary gland. So how do you know which is which? Well, that's the question. So if you have the pituitary gland here again, and now you have a tumor, let's say that's this size, and it's making prolactin, that can cause an elevated prolactin level. Now let's say you have a big gigantic tumor, and this tumor is not making prolactin, okay? But because it's a very large tumor and occupying half of the pituitary gland and putting pressure, well, the prolactin level goes up as well. The question is, the important point is, how high is the prolactin level?
Oh, is it 200?
No, that was just a rhetorical question. How high is the prolactin level will tell you the answer. Is it secreting or is it pressure? With pressure, the prolactin level never goes above 200. So if you have almost never, I mean, again, in medicine we never use never or no or yes, but or guarantee or 100%. But if the tumor is actively releasing prolactin, then the prolactin level can be very high. But from pressure, you can't really get the prolactin level to be above 200. So if you have, so two things that matter. What is the size of the tumor? The bigger the size of the tumor, the higher the prolactin level if it's actively secreting prolactin.
If the tumor itself is.
Right.
If I may comment on her comment about the independent production of hormones, the beginning of my Cushing's diagnosis was that my doctor, my nephrologist, Dr. Gordon, at my annual physical, detected increased levels of testosterone and something called DHEA.
Right.
And he simply said to me, we want to check those again in 3 months. I always do what he says. I went back in 3 months. They were still high. Then we began the tests with cortisol, and as those became more and more indicative of Cushing's, he then said he would bow out and turn me over to an endocrinologist. But it was, in fact, testosterone and DHEA in my case that caused him, and I had no physical symptoms at all, simply the mental ones which caused the inappropriate rage, which would kind of...
Right, so I know you're still uncomfortable about this. I'm going to come back to it and have you understand, but let me address this real quickly. Okay. Yes, again, I made a very simplified cartoon that ACTH results in the release of cortisol, but ACTH also results in the release of DHEA and testosterone, and so these signals don't necessarily just have one function. But in the production, in the steps that lead to cortisol production, there are branch points that result in the production of DHEA and testosterone as well. So oftentimes in people with Cushing's disease, when the ACTH level is elevated, testosterone and DHEA is also elevated. And that's why people with Cushing's can present with facial hair or loss of scalp hair. So there is one hormone being off can have a domino effect and result in other hormones being off as well. So the important thing to point out here again is that the pressure on the pituitary gland, if it's causing high prolactin level, the prolactin is usually not very, very high. So tell me, what is the prolactin level in you?
200.
200. And what is the size of the tumor?
Robin's egg. I mean, it's, like say this is the pituitary gland. It's pushing against it. It's squeezing it.
Right.
It's flat. It's just flat.
So that's probably not releasing prolactin. That's probably due to pressure.
On the pituitary.
On the pituitary, yes. So that tumor is probably not actively releasing prolactin, because you would expect the prolactin level to be in the thousands. If you have a Robin's egg tumor, the prolactin level should be, 10,000. I mean, we've seen it. The record I think was when they had to dilute a sample several hundred times because the prolactin level was 50,000. So when you have a tumor that large, it's going to, if it's actually releasing prolactin, the prolactin should be very, very high. And if it's only 200, it's just due to pressure
On the adrenal, I mean on the pituitary.
on the pituitary gland. Now,
Could it still make those other, with the other, like the adrenal or the other?
so it could cause the other hormones to be depressed because of the pressure. Usually pressure causes prolactin to go up and the other hormones to go down. So it could be that you've gained a lot of weight. You don't have Cushing's syndrome, but you gain a lot of weight because it's putting pressure, and so thyroid function may not be as great
So it's wreaking havoc on everything.
on the rest of the gland.
Okay,
It's the thing that you just mentioned. Could the tumor grow and put pressure so that other hormones aren't made? Absolutely. Now it could be that you measure it and the hormone level looks okay, but maybe your level was better before you had the tumor. And maybe the level is still normal in the normal range, but not normal for you, where it should have been. So the thyroid hormone level may have decreased 50%, so you gained 20 pounds. It's not because your tumor was making cortisol like the Cushing's patients, but because the other hormones were not being released properly. In fact, people with prolactin tumors or high prolactin of any source generally gain weight. Generally gain weight. They don't have a 100-pound weight gain like the Cushing patients do, but they do have weight gain. They don't develop, severe depression. In fact, or you were concerned because you were very angry or enraged. People get admitted to the Neuropsychiatric Institute for severe psychosis, and it's due to Cushing's. We have patients who have severe manifestations.
I'd like to add one thing since we're talking about that. What I noticed, Dr. Cohan, a lot is that for some endocrinologists that are not quite as experienced, where they'll see a tumor like yours, for instance, even though it's very large, and the prolactin levels, they'll start treating automatically medication, and they haven't, and then the tumor is non-responsive, but they just keep upping medication. And at that time, I hope people would switch to another form of an endocrinologist, because that tells me that it's not producing the prolactin. So that seems to be a problem.
So let's finish this. I mentioned that if you don't know this principle that both tumors can cause high prolactin that secrete prolactin and also pressure, if you follow that logic, let's say that you, in your situation, again, I don't want to pick on people or take cases, but let's just say that it was felt that this big tumor that somebody has with a prolactin level of 200 is misclassified as a prolactin producing tumor. So the doctor doesn't say, okay, well, it should have been, if you have a tumor that's 2 or 3 centimeters, the prolactin should be 10,000, and mistakes this as a prolactin tumor, even though it's only 200, well, then the doctor will come and give you a medicine to lower the prolactin level, or a treatment for a prolactinoma. And then he or she is going to measure your prolactin level a month later, and it's going to come down. So he gave you a medicine, Dostinex, bromocriptine. The prolactin level went from 200 to 2. It's now normal. And he's happy or she's happy. Great, your prolactin level is controlled. But because this was not a prolactin-producing tumor, it was just due to pressure, the tumor is going to continue to grow. So the medications that lower prolactin only shrink the tumor if the prolactin is made by the tumor, not if it's due to pressure.
Wow. That's why this doctor said right away it's surgery, because of the size of it.
Right. So if the size is that big, then the prolactin should be much higher if it was secreting it. And so in fact, what you have is a non-functional tumor with a high prolactin level, or I think what you have. I mean, this is just a support group. It's not medical advice. But you know, so it has to be, everything has to be taken into account.
No, but it answers why I feel some symptoms that are mentioned, but that I'm not diagnosed with, so that
Right.
Cushing's.
That's right. And that's why the term non-functional is not a very good term, because you think, or sometimes we used endocrine inactive, hormonally inactive tumor. And these are not very good terms, because it's in fact causing lots of problems.
Would that be like hypopituitarism or hyper? Which is
Hypopituitarism is an underactivity of the pituitary gland, which can occur because there's pressure or compression. And hyperpituitarism is usually a term used to denote tumors, because the tumors are overproducing a particular tumor. Yes.
When I first got diagnosed, this was at the doctor that went over my MRI results with me. Came in with the MRI results with notes from a doctor out in the hall who had to draw a diagram and show him where the pituitary gland was. So, and he's the doctor who gave me my prescription for bromocriptine. And he said, I'm starting you on a low dose because it'll drop your blood pressure and it'll need to gradually build up. He told me to just take one pill that night. I took a pill that night and I was out the next day. Freezing cold, could hardly walk without fainting. So I Googled it. Google's been my doctor. And I found that it said an experienced endocrinologist will typically give, I don't remember the number, but it's 4 times the amount. He gave me 4 times the amount that it said an experienced endocrinologist will get. And even though on the thing it said do not stop taking this, I couldn't get any medical advice, and I didn't want to keep taking 4 times the amount that I should be on. I didn't know what to do. So I just cut my tablets up and I gradually decreased them. And I only took it for like 4 days and then I just stopped. And then about a month later, I had a period one day. And that's it. And then I haven't had one since. So what are the dangers of stopping the medicine once you go on it? And I don't even know where to begin with. I don't mind going back on it. I just want to go on it right, if that's the right way.
Right. So, I mean, again, the question is about prolactin tumors. These are tumors that are generally felt to be treated with medications. Bromocriptine is an older medicine. We generally don't use it very much anymore because of the side effects that you had. I mean, people can feel horribly ill from taking bromocriptine, even if you take the correct dose. I don't know, when you cut it in quarters, did you still feel crummy?
I still didn't feel great.
Yeah,
I was able to function.
So bromocriptine can have a lot of side effects, and that's why newer medications are available. What happens if you stop the medicine? Well, the prolactin will then gradually creep up again. And so then the prolactin concentration goes up, you continue to miss periods, lactation can occur, you can feel down because when the estrogen levels are down, mood changes can occur, lack of interest in sex.
And the tumor can sometimes grow.
And the tumor can continue to grow.
Stimulate it to grow?
Stopping it?
Stopping the
It
medicine?
doesn't stimulate it. You just go back to where you were before. Yeah, so if you stop it, you don't cause additional harm. It just things go back to how they were before. So you don't get the benefits anymore. But there are.
You have to watch to make sure it's not growing.
And then I also read on Google that, I don't remember where I read it, but it said something about this, I'm not sure why, but they found that for people who go on tumor suppressing medication, and then their cycle's regulated, kicks back in, for people who, that's their case, and then they conceive, get pregnant, and it's common for the tumor to go away completely.
Well, if you've been on a medication, whether it's bromocriptine or the newer medicines for prolactin-producing tumors, and you've been treated with that medicine for long enough, the tumor can go away. It could no longer be visible on MRI. The problem with that is that person still needs to be monitored because with time, it can come back. So it's a tricky thing. I mean, there's some data that with the newer medications to treat prolactin tumors, if a person has been treated with that medicine and has a small tumor and has been treated for 4 or 5 years, and the tumor has gone away, and now you stop the medicine, those patients seem to be free of tumor for several years. But that's how long the study went for, and so we don't know what's going to happen after 3 or 4 years. It may come back again. So yes, that's why I mentioned initially that medicines are often used for prolactin tumors because it can control the hormonal problem and shrink the tumor to disappearance, and you can then stop the medicine, but you have to then always be monitored to make sure that the prolactin level doesn't come back again. Yes?
How likely is it that people have a non-producing tumor, get operated on, and the tumor recurs, as in my case, all of a sudden as a producing tumor? Or is it more likely that one person keeps having the same kind of tumor and it was just overlooked in the first case?
Yeah, I would think that it's the latter, which is the second thing that you said, that probably there was some hormone production by that tumor at the very beginning. Now, the hormone production may have been subtle. It may have been intermittent. There was 2 people who had symptoms of intermittent Cushing's. We don't know why that happens, that all of a sudden the pituitary tumor is active and releasing signal or hormone, and then it becomes quiescent. It's unclear, but perhaps yours had a relatively long dormant period, and then it activated. Bye. Goodbye. And it got activated. So I would think that it probably was there all along, but because it's rare for a person to have tumors that are doing different things. It's possible. We talked about tumors that could co-secrete hormones, so there's a possibility, but probably there was a subtle hormonal problem earlier, and it just became more active.
Because of the operation, maybe? Or?
Not it's unlikely that a surgery would cause a tumor to take off, to my knowledge.
So I'd just like to know, since I'm 7 years down the road, what are some of the symptomatic things that people experience down the road, adding age and the fact that everything is exaggerated internally?
Yeah, well, this is the situation. She said that her internal organs are 2 to 3 times normal size. She had acromegaly. You all know that that's a overproduction of growth hormone. And the internal organs can get bigger. The most dangerous would be the heart enlarging.
I already know that's enlarged beyond belief, because I don't even have a resting motion. It's like my heart goes like that. So they thought they put me on beta blockers, and heart specialists went, look, lady, you survived that brain tumor, let's just leave you alone. Let's not add anything to
You have a big heart.
As long as you're doing
You have a
things,
big heart.
keep going.
You have a big heart. Yeah. There are long-term complications of having an enlarged heart. It turns out that a lot of if growth hormone excess has been going on for a long time, and as maybe in the case with you,
I was 46 when this hit, so.
that you had maybe overproduction of growth hormone for many years, there is some reversibility, but there's also some things that don't change. Like, for example, the
Size 12 shoe.
yes, you may go from size 12 to a little bit less because there's less swelling, but your foot is not going to go back to the size that it used to be, because the bone, once it's grown, is not going to shrink again. The arthritis, if it was long enough and you had significant arthritis, and you said it very well, spatial anatomy of the joints.
That's what I asked, like the third year going into it, because I said sometimes I can bend my hand around and it feels like it will be disjointed.
Right.
And then my physician said, oh yeah, we've had people come in, acromegaly, and they'll disjoin an arm or leg or a knee. And I'm going, why didn't you guys tell me that? I'd have been a little more easier on my joints. I'm going,
Right.
I can walk up that stairs. No, I'm not supposed to.
Those things can occur. The arthritis could be pretty debilitating, and some patients with long-standing acromegaly, the effects on their joints can be such that they're maybe bound to a wheelchair, not be able to exercise very much. Some of those changes are irreversible. Heart function can improve a little bit, but the enlargement doesn't go away. Why did you grow after your tumor was diagnosed? I mean, was the growth hormone levels normalized as soon as the tumor?
I believe so. That's why they looked at me and they went, there's got to be a mistake in your chart. And they went, no, there's not. You really and truly are 5'10". My husband and I used to be able to look at each other in the eye. Now we can't. We've got to go like this.
Yeah. It's hard to
Getting
explain
in and out
that.
of, cars, doorways, all of that stuff. I said, I'm kind of like a little shack there, so to speak.
You're special and have a big heart.
That's
right.
And the
So
other
I
thing
don't-
is
I don't
they
know how
have
to
a
explain
thing
that.
with the cholesterol, because I really don't want to go on cholesterol meds, and I know that without the pituitary, my cholesterol is going to be crazy anyway, because that's the balancing act of this thing.
Right.
So
So
I keep putting my endocrine guy off as I go, but the pituitary is not functioning, so.
right. So when the pituitary is not
It's gonna make a difference.
functioning properly,
I don't have
and
a pituitary going on,
and-
that's a stop, that's it.
and
You're
the
still making your own cortisol, right?
Cortisol's the only thing that's balancing out, and I gave him Synthroid because my thyroid kicked in after I went to a Benny Hinn procedure.
well, that's good.
Yeah, 3 days after, they go, that's impossible. I go, can't help it, that's the way it went.
It's unusual for pituitary function to come back after many years, but it's possible.
Down the road, 3 days later,
It's
I went for blood work.
it's unusual for growth to occur after a tumor has been treated, but yeah, cholesterol problems occur partly because we talked about, there's crosstalk between hormones, there's crosstalk between pituitary hormones and other things like cholesterol. And if the thyroid dose is not enough, perhaps cholesterol can go up. You're not on cortisol, but if somebody's given too much cortisol, the cholesterol can go up. If the growth hormone levels are below normal, that can cause cholesterol problems.
That's what I figured. I just hate to add a mid to the mix when I don't think it's the right readings.
Right.
I think.
So
because I don't have the right balancing going on to begin with.
So cholesterol problems can be the sign of a pituitary tumor. I mean, but a lot of people have cholesterol problems. They don't have a pituitary tumor. But again, the important point here, just to make some unifying point from what you said, is that there could be lots of different manifestations of a pituitary hormonal problem, even though that you're replaced on the hormones to the best that they can. And there could be long-term effects that are not reversed by surgery.
And most of the doctors just look at me and say, you're a walking miracle and we don't want to touch anything that's not already broken. So just keep going. Do your blood work every 4 months and see you around.
Dr. Cohen, I had one quick question. You said bromocriptine is something, this is kind of an old medication. What is it you recommend now, or what do you normally use?
We usually use something called Dostinex, and Dostinex. And that was a fairly expensive medication up to recently when it became generic, and now there's a generic form for that as well, with that came available.
What kind of side effects, I guess, did bromocriptine produce? I don't know if I'm having them or not. I know it's not shrinking my tumor, it's just not growing. But
Right. So, I mean, it could have lots of side effects, from nausea to mood changes to feeling dizzy and lightheaded to nasal congestion to just anything. I mean, not everybody has those symptoms. Some people do fine on bromocriptine. Most people have some side effect. Some people acclimate, and that's why you have to cut the pill into a quarter and start with a quarter and give it some time until the body adjusts to it.
do these
But there's
actually
less
shrink the tumor?
if it's a prolactin secreting tumor. So if there's a prolactin producing tumor, those medicines shrink it. We're going to stop on that note, but I'll stay if other people have specific questions. Thank you, everyone, for coming.
Thank you.